Hello, good morning, good afternoon, or even good evening, and a very warm welcome to this 14-part podcast series being specifically designed to support undergraduate sports therapists in their quest to achieve a greater foundational understanding and appreciation of the clinical assessment process. We will be discussing the key ingredients of a successful clinical assessment and highlighting the important and specific aspects which have particular relevance to the assessment of sporting and active patients. It's certainly not meant to replace what you've been taught in class. So, clinical assessment. All clinical assessment should take the form of a recognisable, reliable and repeatable protocol. A detailed subjective assessment is followed by a thorough and appropriate objective assessment. With experience, the sports therapist will be able to prioritise their plan of objective assessment to incorporate the most appropriate assessment techniques for the presenting patient and condition. The resulting assessment must aim to enable the clinician to make a reliably informed decision regarding the presenting injury or condition. Differential diagnoses, which are a short list of the most likely conditions that the patient may have, or the most likely involved tissues, must be considered. It's not always possible or appropriate to attempt to reach a confirmative diagnosis, and as such, a clinical impression of the involved tissues should be ascertained, importantly including a set of measured examination findings. When presenting with a patient complaining of pain, first thoughts could be to consider whether there is a possibility of the patient having one of the common conditions that affect the body region in question. So, for example, at the knee, this could be an osteoarthritis, ligamentous injury, which most commonly at the knee will affect the MCL, the medial collateral ligament, or the ACL, the anterior cruciate ligament. Or it could be meniscal damage, or patellofemoral pain syndrome. The therapist would also be considering or ruling out other conditions, such as, again at the knee, a musculotendinous strain of the quadriceps, hamstrings or gastrocnemius, or a patellar tendinopathy, or a bursitis, such as infrapatellar or suprapatellar bursitis, or Osgood-Schlatter's syndrome, which is a growth spurt condition causing pain at the patellar tendon insertion of the tibial tuberosity. Other less common knee conditions could include osteochondritis dissecans, which is a fragmentation of cartilage and subchondral bone, or the bone directly underneath the hyaline cartilage, Plica syndrome, which is irritation at the anterior knee from thickened strands of the synovial membrane, or fat pad impingement, which is a nipping or irritation of the infrapatellar fat pad, which sits underneath the patellar tendon. The aim of the clinical assessment is to identify which structures are affected, the etiology or cause of the problem, the main symptoms, the severity of symptoms, the amount of tissue damage and type and level of pain, and what functional deficits are apparent. The sports therapist must also consider the additional individual factors which will influence the initial treatment and advice, and the longer-term management and recovery. There are a number of confounding factors which must be considered when interpreting examination findings. Confounding factors are what can confuse or skew test results. Obviously, the therapist must acknowledge the limitations of any of the tests used, and particularly their sensitivity and specificity, which are the evidence-based indicators of their reliability. Hattam and Smeatham, in their 2010 text, Special Tests in Musculoskeletal Examination, an Evidence-Based Guide for Clinicians, explain that sensitivity may be expressed as a percentile, and that it is a marker of how reliable a particular test is to positively identify a patient with the condition that the test is designed to assess. A test with a 98% sensitivity rating, for example, should therefore be recognised as being a fairly reliable test to clinically suspect the condition, in conjunction with other test findings. Specificity may also be expressed as a percentile, and it's a measure of the proportion of people without the condition of interest who will present with a negative test. Although this might sound quite complicated, there is a simple way to remember things. sensitivity might be thought of as snout, and specificity as spin. Any test which has a high sensitivity rating is effective at ruling the tested pathology out, as in snout, i.e. this is if the test result is negative. Sensitivity is measured by the proportion of people with a condition of interest or target condition who have a positive test. Any test which has a high specificity rating is effective at ruling the tested pathology in, as in spin, i.e. this is if the test is positive and confirms the diagnosis. Specificity measures the proportion of people without the condition of interest or target condition who have a negative test. So basically, any test with a high sensitivity or specificity rating is an evidence-based and relatively reliable test. However, there are other factors influencing the reliability of any clinical test. The sports therapist should recognise the potential for observing or achieving what are termed false positive or false negative test results. Such results could occur through poor positioning, poor handling, poor feedback, or poor interpretation of the test. Additionally, we must realise that sometimes special tests may not be appropriate or reliable simply because of the acuteness of the injury, such as when there's a great deal of inflammation and the swelling that goes with it. Inflammation is characterised by 5 classic signs: redness, heat, swelling, pain, and impaired function, and it's mainly associated with the first 24 to 72 hours of a soft tissue injury. It's the hallmark of the acute stage of healing. However, we will see in the clinic conditions demonstrating re-injury and a return of inflammation, or chronic and prolonged inflammation. Inflammation can also be a hallmark characteristic of certain systemic conditions, such as rheumatoid arthritis or ankylosing spondylitis. Once the clinical assessment has been completed, the therapist should have attained a firm clinical impression of the patient's condition, its causative factors, its etiology, the patient's functional impairments, and the degree of tissue involvement. Clinical assessment of patients attending for sports therapy include a subjective assessment, which is the thorough history taking, and objective assessment, which is the practical, technical, and measurable part of the assessment. The objective assessment will normally include general observations, specific postural analysis, possible gait assessment, which is the assessment of the patient's walking mechanics, the clearing of associated body regions. This is undertaken so as to rule out or include the possibility of the patient's pain or problem being caused or affected by another region. Joint movement assessments. These will be active, passive, accessory, and resisted tests for the affected regions. Muscle length tests, ligament stress tests, special tests, functional tests, and palpation. It's normal to begin clinical assessment by utilising a standardised routine. As your confidence, knowledge, and experience develops, you will be able to make informed decisions on what particular tests to include or leave out. When exploring the patient's main complaint, the focus of subjective assessment should be on the patient's perception of the cause of their injury or problem and the type, extent, and severity of their pain. The therapist should also attempt to identify whether there is any muscular weakness or sensory abnormalities, both of which can result from neurological impairment. The subjective assessment should clarify the appropriateness of continuing on to the objective assessment, or whether referral would be the more appropriate course of action. The sports therapist must consider referral when presented with any contraindications, red flag signs or yellow flag signs. Not all contraindications warrant a referral, but where the patient has, for example, an underlying medical condition such as CHD or congested heart disease, unexplainable pain, recent cancer, a recent operation, hypertension, or unstable epilepsy, amongst many other conditions, then the therapist is required to seek medical opinion prior to offering any further intervention. Local contraindications are conditions that mean that the affected area should not be treated, it should be avoided in any particular treatment. These include conditions such as skin irritations, like psoriasis, fungal infections such as athlete's foot, viral infections such as warts, or vascular conditions such as varicose veins. Red flag signs are indicators of possible serious pathology. These can include recent history of cancer, constant worsening pain, recent unexplained weight loss, feeling very unwell, which is known as malaise, a persistent cough, any abnormal bleeding, and much more. Yellow flag signs are psychosocial factors such as fears, negative behaviours, personal issues, and other external stressors, which again the sports therapist must be vigilant to, and there may be occasions where the patient requires referral to an additional source of support. The subjective assessment will begin by focusing on the patient's situation and background, so we must ascertain their name, address, date of birth, telephone and email contact details, GP name and contact details. We must explore their medical history, current medications and any recent or planned visits to other healthcare professionals. For some patients this will take longer than others, if for example they have a complicated medical history. We require a good understanding of the patient's working situation, hence we should document their occupation, and if we are unsure as to the nature of this, we must ask further questions. It's also essential to explore the patient's exercise and sporting routine. We must be particularly keen to identify the patient's level of fitness and fitness knowledge, and what their fitness routine consists of. Similarly, we need to know about their sport, the level of sport that they play, what position, whether they have any important events coming up, or perhaps their longer-term sporting or fitness goals. If we are unfamiliar with their sport, we should ask further questions. We must not miss anything of importance. We must record clearly, legibly, in black ink, all necessary information. You must remember that the consultation form is a working and legal document. It may be requested by the patient at any time for their own interest, or for insurance or other medical purposes. It may be used by yourself or your practice to demonstrate your professionalism, your findings and your advice and your interventions, and importantly, to support your actions should you be required to defend yourself against any claims of negligence. During the subjective assessment, you must record on the consultation form everything of relevance that has been discussed with the patient regarding their health and medications. It's essential that you gain the information that you, as a training healthcare professional, require so as to go about your work safely and efficiently. As a sports therapist, you must explore the patient's main complaint and any other presenting problems. If there's more than one complaint, it's usual to number the complaints, such as problem 1, problem 2, etc. For the main complaint, an appreciation of the history of the problem must be recorded, whether it's a gradual or non-specific and insidious onset. Insidious means that there's no immediately identifiable reason. The patient's condition may have an obvious history. It may be due to a single traumatic event or due to a distinct change in their normal training regime. A detailed analysis of the mechanism of injury, the MOI, is necessary as the direction and magnitude of the force applied, whether it is extrinsic, as in an external force, such as from contact with an opponent or impact from an implement, or intrinsic or internal, such as an overstretch or overloading of muscle. This will provide important indication as to what structures may be damaged. For example, when a foot is bearing body weight and is fixed to the ground, perhaps with studs into the grass, and a twisting impact occurs, such as a forced external rotation with a valgus or inward stress to the knee, this could indicate damage to the ACL, and from one single traumatic non-contact event. An example of a different mechanism of injury could be the novice distance runner, who, with an underlying pes planus, which is simply a flattened medial longitudinal arch, and a genu valgus of the knee, which can be simply described as a knock-knee type posture, and who has recently begun training for a half marathon, will have a certain vulnerability to overuse, repetitive stress injury, if their training is not carefully progressed and their biomechanics and footwear not properly addressed. When the athlete's posture and movements are less than ideal, there is potential for unwanted stress and potential for injury when new exercise regimes are embarked upon. Two of the key aims from history taking are the determining of which structures have been damaged and the extent of damage to these structures. It's important to ascertain whether the patient has a significant injury which requires immediate attention. Indicators of this include severe immediate swelling and pain, the joint in question locking or giving way, joint laxity, which is associated with ligamentous injury, and the presence of crepitus, which is a grating sensation which may be heard or felt. Any other concerning, suspicious or confusing signs or symptoms must also warrant expert opinion. The therapist should aim to identify when symptoms indicate a more severe injury, such as a ligament rupture, meniscal tear or loose body within the joint, which may require referral for early medical investigation or even possible surgical intervention. The severity, irritability and nature, which is abbreviated as the sin of the injury, must also be gauged. For severity, pain levels can be graded on a verbal, visual analog or numerical rating scale, as in a VAS or an NRS, 0 to 10. The therapist should ask about any grinding, locking, catching or giving way of the affected joint, which can be indicative of osteoarthritis, meniscal injury at the knee or ligamentous injury. Certain positions may increase or reduce discomfort, hence the therapist must ask what aggravates and what relieves. It's also important to ascertain whether the patient has had any other treatment or surgery on the region, and whether they have any pain or other symptoms above or below the affected area, as some problems can refer pain to other regions. During the subjective assessment, the sports therapist should be thinking ahead to which tests are going to be important to investigate the patient's presenting problem. For a new patient attending with an injury, the therapist must consider the relationship of that particular region to the rest of the body. They should consider which regions could potentially be the cause of symptoms at that affected region and what structures and tissues are involved directly. On completion of the subjective assessment, the sports therapist should be formulating their clinical impression of the patient's main complaint. The objective assessment is the practical examination of the patient, based on orthopedic principles using a set of recognisable, repeatable, reliable and valid test procedures. Results are clearly documented on the patient's record form and referred to in any follow-up sessions or communications. The sports therapist should work with a firm rationale for all of the selected techniques, and it's their responsibility to perform the assessment correctly, eliciting the necessary clinical findings to enable a decision on the suitability of the patient to receive sports therapy intervention. The objective assessment must involve a process of clinical reasoning, as the therapist interprets the amalgamated subjective information and the findings from observation, movement, palpation, special tests and functional tests. The therapist must develop proficiency in test techniques, making sure the patient is comfortable for each technique, recognizing what is normal for each patient, being selective in what tests are performed, i.e. aiming more for quality of test performance rather than performing an unnecessary quantity of tests. Careful modification of techniques for the condition presented and the tissues involved, recognition that some patients present with comorbidities or additional or underlying conditions which mimic the target condition. Practitioners must aim to achieve a high level of comparable intra-tester reliability and for efficiency in their practice. Intra-tester reliability simply means that similar test results will be ascertained regardless of who delivers the test. Observation begins as soon as the patient is in the view of the therapist. Initial impressions can be made on the patient's stance, posture, body type, attitude and approach to movement, gait and general body language. During the observation, the patient's skin and superficial tissues are inspected for any abnormal signs. Muscular contours are also observed during observation for general tone, symmetry, atrophy, imbalance between regions, etc. Imbalances of muscle bulk can relate to unilateral hypertrophy of the larger limb or the atrophy on the smaller limb that can occur following prolonged periods of immobilization or interruption to the peripheral nerve supply. Where muscle bulk or joint circumference differences are suspected, a girth measurement can be easily taken by measuring a line from a structural landmark with a tape measure and comparing left with right. Bony prominences and joint lines should be inspected for signs of deformity, asymmetry, thickening, and localized intra-articular swelling or more diffuse joint effusion. The affected region should be observed statically, both in standing and seated positions, and if possible, dynamically during walking. The patient will ideally be in shorts and bare feet. The therapist should position themselves appropriately so as to appreciate all required information. This will include getting eyes level with structures and identifying landmarks with finger and thumb tips. When assessing peripheral regions, both sides should be observed and compared anteriorly and posteriorly, and from right and left lateral views. Observations begin as soon as the patient is in view. The ideal postural alignment will show with no significant bilateral or unilateral deviations. Kendall et al., in their classic textbook Muscles, Testing and Function, Posture and Pain, 2005, present detailed ideal and commonly deviated postural conditions. In the anterior view, the therapist can observe for such presentations as head position, clavicle and acromial position, thoracic rib cage symmetry and sternal position, shoulder position, angle of flexion at the elbow, resting height and position of each upper extremity, pelvic shift, lateral pelvic tilt, leg length discrepancy, anterior or posterior pelvic tilt, hip angle of inclination, as in coxavera or coxavalga, femoral anteversion or internal femoral torsion, femoral retroversion or external femoral torsion, genivalgus as in knock knees, genivarus as in bow legs, Q angle, patella malalignment, patella barger as in an inferiorly positioned patella, patella alta as in superiorly positioned patella, squinting patella, which is associated with femoral anteversion, frog-eyed patella, which is associated with femoral retroversion, enlarged tibial tuberosity, indicative of Osgood-Schlatter syndrome, foot angle, associated with both hip angles and the tibial torsion, medial longitudinal arch rigidity or insufficiency, navicular drop, hallux valgus, or hamartose. It can be useful to ask the patient to stand with feet together to gain an improved appreciation of any genivalgus, and this may show with the knees touch when the feet are apart, and genivarus, which will show with the knees apart with the feet when the feet touch. Similarly, it's useful to ask the patient to extend and supinate their arms, as in the anatomical position, so as to assess their carrying angle, which is the angle created by taking a line through the humerus and a line through the middle of the forearm. A normal carrying angle is said to be approximately 5 to 10 degrees in males and 10 to 15 degrees in females. Anteriorly, the therapist will also assess surface contours and muscular presentations. The thickness and colour of superficial tissues can be observed, as can any localised extra-articular swellings, possibly indicative of bursitis, particularly those around the knee. The suprapatellar, prepatellar, infrapatellar, pes anserine and ITB bursa. In the posterior view, the therapist will again look at head positioning, looking for any shifting, tilting or rotating of the neck. The spinal region should be closely inspected for any deviations, which could indicate structural or functional scoliosis or muscle spasm. The positioning of the scapula must be assessed for any asymmetry or excessive adduction, abduction, elevation, depression or rotation. You should assess for any pelvic tilting, which can be lateral or anterior or posterior. Hip angles and genivalgus and varus can be observed. The popliteal creases need to be compared for their levels and angles. At the ankle, valgus heels are commonly associated with pes planus, as in the medial longitudinal arch insufficiency. The Achilles tendon must be observed for any thickening or reddening and for its course down from the calf to the calcaneus, which may be bowed in the presence of valgus heels. Also in the posterior view, the presence of capsular distension may be observed, as in Baker's cyst, which mostly associated with an arthritic knee. The upper extremity should also be assessed for any asymmetry. The skin and body contours, including musculature, must also be closely inspected. Laterally, the therapist should observe for excessive or reduced spinal curvatures, such as exaggerated kyphosis or lordosis, flat back or sway back. The presence of anterior or posterior pelvic tilt, which may be bilateral or unilateral, genu recurvatus, as in hyperextending knee, or genu flexus, as in a flexed or hypoextending knee. Musculotendinous contours of the lateral thigh, including vastus lateralis, ITB, and biceps femoris, and calf, as in gastrocnemius, may be observed. Similarly, ankle and foot positioning must be observed. In the lateral view, the shoulder may be assessed for any medial rotation or protraction. If full weight bearing, FWB, and ambulation, walking, is possible, then the athlete's gait may be assessed. Clinically, the athlete can be asked to simply walk up and down the room, or can be observed on a treadmill. Although this may be considered functional testing, the therapist may elect to include gait assessment prior to any other objective tests, simply to provide initial clues to the irritations and limitations. The therapist should aim to view the athlete from all four sides and be able to identify obvious imbalances or deviations from the norm. The basic gait sequence incorporates stance and swing phases, and the sports therapist will be observing for basic confidence or apprehension in walking, stride length and width, foot angle, trunk movement, and reciprocal arm swing, any linear or angular displacement, and any issues associated with altering cadence or changes in direction. Painful or antalgic and arthritic and restricted or arthrogenic compensatory gait patterns can show as the patient having a reduced stance phase on the affected limb, walking with a limp, or an altered swing phase, circumduction movement. David McGee, in his Orthopedic Physical Assessment text from 2008, presents a differential diagnosis of non-antalgic gait limping, including equinus or toe-walking gait, most commonly resulting from simple tight posterior calf musculature, congenital club foot or cerebral palsy, and Trendelenburg gait, which is associated with weakened and poorly recruiting hip abductors. The therapist should aim to identify any limitations or increases in ranges of movement, much of which will be best observed in the lateral view. Restrictions may result from tight posterior leg structures such as hamstrings, gastrocnemius, or the joint capsule. Mechanical derangement within the hip, knee or ankle joint, such as with a femoroacetabular impingement at the hip, a meniscal tear of the knee, or an osteochondral fragmentation of the ankle. Furthermore, the therapist should aim to identify any patellar maltracking, abnormal tibial motion relative to the femur, possibly indicative of instability. When assessing localized problems, the sports therapist must establish whether the problem is due to a local injury, or if structures above or below the region are involved. Hence, unless it's absolutely clear that the injury is a local problem, then the related regions must be screened or cleared. For the shoulder, it would be essential to screen the cervical spine and the elbow. For the knee, the lumbar, pelvic, hip and ankle regions should be screened. Generally, active movements with overpressure, if appropriate, are employed at each of the associated regions. Each movement is assessed for any symptom response and is compared contralaterally. If symptomatic, then a more detailed examination will be required. When clearing the spinal region, flexion, extension, lateral flexion left and right, and rotation left and right can be performed. The therapist may elect to assess what are known as active quadrant movements. These are combination movements. Quadrant tests are recognised as being potentially more provocative, particularly to the intervertebral foramen and associated peripheral nerve roots. We'll now have a quick consideration of some standard assessment procedures for the nervous system. The cervical, brachial, lumbar and sacral plexi serve the upper and lower extremities. Problems affecting the nerve roots of these plexi, or the peripheral nerves which continue from them, such as with impingements, neural tensioning, neuropraxia or neurotemesis, can lead to referred symptoms such as pain or motor or sensory deficits, which then present at an affected peripheral region. Trigger points are another common cause of referred myofascial pain. Whether the pain is radicular, i.e. of neural origin, or referred from active trigger points, it's most commonly referred distally. It may also be necessary to explore the nerve supply to the affected region, particularly where there's weakness, atrophy or muscle wasting, or paresthesia, which is any abnormal sensation, or where there are any other assessment findings indicative of a possible neural problem. A myotome is a group of muscles innervated by a particular spinal nerve root. Myotomes are tested with a therapist offering manual resistance against the patient's contraction for a minimum of 5 seconds. A dermatome is the sensory distribution and area of skin relating to a single spinal nerve root. Dermatomes are presented as generalized maps which guide practitioners to the approximate distribution associated with each spinal nerve root. Dermatomes relating to any particular region are assessed by gauging the patient's response to light or sharp touch. The therapist slowly traces circumferentially and systematically around the peripheral region. The method must compare left with right and allow opportunity for the patient to report any abnormal or loss of sensation. Reflex tests provide further information regarding the functional innervation or nerve supply of the affected region. Deep tendon or spinal reflexes assess the integrity of the sensory, muscle spindles and the efferent fibres, and motor, or the efferent fibres, nerve pathways involved in the reflex arc, essentially checking the response of a muscle to being stretched, i.e. a stretch reflex. The patient must be relaxed and the muscle placed in a position of slight stretch. The tendon is lightly tapped 5 or 6 times. By tapping a number of times, the practitioner may observe an increase or reduction in reflex activity, which can indicate the possibility of upper motor neuron lesion. An increased response indicates the possibility of a UMNL, or signs of nerve root involvement, or lower motor neuron lesion, where a reduced response indicates the possibility of an LMNL. A normal reflex response is an observable or palpable contraction of the tested muscle and slight joint movement. The abnormal reflex responses include clonus, which is very brisk and spasmodic, or exaggerated responses, which are possibly indicative of UMNL, or diminished or absent responses, which are the most likely presentations in patients attending in a sports therapy clinic and are indicative of an LMNL, a lower motor neuron lesion. Reflexes are not always easy to elicit and can produce false positives. Reflexes are always tested bilaterally and on their own are not conclusive. The main reflexes which are tested include using a reflex hammer are the biceps for C5, C6, triceps for C7, C8, brachioradialis for C5 and C6, patella for L3, and Achilles for S1. Other nerve tests should usually be performed in the presence of suspected nerve irritation or radicular pain. For the upper extremity, the upper limb tension tests, or ULTT 1 to 3, are employed for assessing irritation or limitation of the main peripheral nerves of the upper extremity, namely the median, radial and ulnar nerves. For the lower extremity, the following are used: the straight leg raise test, or SLR, for sciatic nerve irritation, the slump test for sciatic nerve, dural sheath or spinal cord irritation, and the prone or side-lying bend test for femoral nerve irritation. Active or physiological movement testing is performed to assess the patient's functional ability or apprehension to move affected joints. Active movement should be briefly explained and demonstrated by the therapist and then performed by the patient without assistance from the therapist. They are undertaken initially to assess the patient's willingness to perform the movement, to observe for unwanted or compensatory movements occurring, appropriate movement at associated joints, and to clarify where in the range any onset of pain occurs and whether the particular movement alters the intensity or quality of any pain or other symptoms. Active movement should inform the therapist of the possibility of muscle injury, nerve impairment, or joint dysfunction, but they are not confirmative. Overpressure is used to further stress the affected joint at the end of its active range, and is used where there is little in the way of symptom response. If overpressure does not provoke an increase in symptoms, and other findings are normal, then the active movement may be considered normal. Movements of the affected limb should be compared against the contralateral limb and against published norms. But it's important to acknowledge that the patient may have individual abnormalities which need to be considered. Conditions such as hypermobility will show increased movements beyond the normal range. Hence, using the contralateral uninjured limb will provide a more accurate comparison specific to that patient. Range and quality of movement should be assessed. Range may be measured by way of goniometry, inclinometry, tape measurement, or with visual estimation of degrees of movement, as in eyeballing. The patient should be asked to identify where any pain or tightness is felt. Muscle injury, nerve impairment, joint dysfunction, as in impingement, mechanical derangement, capsule damage, ligamentous damage, pain and swelling may each limit joint range of movement. Sports therapists should also recognise the possibility of excessive movement, as in hypermobility and joint laxity. Standard active movements tend to be performed in a single plane. However, the therapist may decide to ask the patient to repeat movements, perform them at different speeds, observe sustained end-of-range positions, or combine particular movements so as to ascertain which specific movements and combinations are most problematic. The findings from active movement assessment must be combined with the results from the passive and resisted tests, along with the rest of the assessment to enable an informed assessment of the patient's condition. Passive physiological movements involve the therapist appropriately positioning the patient so that they're relaxed, supported and comfortable. The therapist can then take each joint movement from a start to end position. The therapist must take care to handle the patient's limb well, avoiding any sudden irritating movements, and to feel and observe the quality and range of movement. Simplistically, it's often said that passive movements assess non-contractile or inert structures, such as ligaments, joint capsule, intra-articular tissue. It should be recognised that passive movements may also provoke a symptom response in musculotendinous tissue, especially where there's a strain, inflammation, spasm, or tendinopathy. Pain can result from either a stretching or compression of an injured muscle tendon unit. The therapist should perform each of the main movements several times so as to feel the quality and identify where any dysfunction is occurring. Restrictions, tension, laxity, crepitus, and local or referred pain may occur. The therapist should move the joint through its mid-range, feeling the quality, prior to moving towards the point of bind, which is the first appreciation of soft tissue tension, and then eventual end feel. The end feel, as presented by a range of authors, including Syriacs in 1982, McGee in 2008, and Petty in 2012, is how the joint feels to the therapist at the end of its range. Abnormality in end feel may result from a mechanical derangement, such as meniscal tears at the knee, causing a springy end feel. Osteoarthritic degeneration can cause a harder bone-to-bone sensation with possible crepitus and muscle spasm, which can lead to a tight end feel. An acutely swollen joint due to ligament or capsule irritation is likely to present with a soft but tight end feel and distinctly reduced range and pain. A more empty end feel can be associated with joint laxity, reduced muscle tension or atrophy, and also low body fat. The empty end feel is likely to present as hypermobile, and less pain and a resultant patient apprehension to the movement is the factor. There are natural or normal constraints to all physiological movements, and these directly relate to the state and structure of the joint and associated muscle and other soft tissues. One further consideration to restricted joint movement is that of the capsular pattern, or pattern of limitation, first presented by Syriacs in 1982 and expanded by others. This is where injury or inflammation of the joint capsule can result in a capsular contraction, leading to a total joint reaction. Hayes et al. In 1994 described the capsular pattern as a joint-specific pattern of restriction that indicates involvement of the entire joint capsule. By comparison, a non-capsular pattern is where there is limitation in a joint which is not characteristic of the capsular pattern, such as where there's a mechanical derangement or tendinopathy. As with active movements, passive movements may be measured by goniometry or other methods, and movement should be compared contralaterally and against published norms. Passive movements must be performed slowly, with correct positioning and handling, and awareness of the potential for symptom response. McGee, in 2008, suggests that if active movement testing with overpressure has been effectively performed, then there may be less of a need to undertake passive movements. It may be considered appropriate to assess combination passive movements of the affected region, such as flexion with adduction or rotation. If pain or stiffness is identified, then graded passive physiological mobilization techniques may be considered as part of a manual therapy intervention. As according to Hengeveld and Banks in Maitland's Peripheral Manipulation in 2005, accessory movements are the subtle, articular joint movements that occur, or should occur, during any gross active or passive physiological movements. Generally classified as being a rolling, spinning or gliding of one articular surface on another, accessory movements allow for normal arthrokinematics. Accessory movements cannot be actively performed in isolation by the individual, but the therapist is able to passively test their range and quality, essentially attempting to clarify normal accessory motion, or identify possible restriction, stiffness or resistance through range, laxity, as in hypermobility and instability, or pain, or provocation of muscle spasm, or any other symptom response. Testing of accessory movements requires precise handling and communication. A number of accessory movements can be assessed at major body regions, and each are assessed in a loose packed position, in the painful position of a free range of movement, or at the end of a limited range of movement, again as according to Hengeveld and Banks. Accessory movements are normally and initially performed in a non-weight bearing position, but weight bearing positions may also be employed. Accessory movements include antero-posterior, as in AP glides, posterior-anterior glides, PAs, medial glides, MG, lateral glides, LG, cephalad and caudad glides, compressions, distractions and transverse glides, TG. As with physiological movements, where there is pain or restriction, accessory movements used as mobilization techniques may be carefully employed in a graded manner to improve the condition. Resistance tests are performed to assess the patient's ability to generate force against the therapist's resistance, identify any pain on contraction or other symptom response, and to gauge the strength or weakness of the working muscles. Isometric resistance tests help to identify the possibility of muscle or tendon injury or nerve impairment, and are less likely to incriminate inert joint structures, as the involved joint is not moving during such a test. The therapist instructs the patient and offers specific resistance to their isometric contractile force, initially in a resting or mid-range position. Sexton et al. From Clinics in Motion 2006 recommend the instruction to the patient to be "don't let me move you," thus enabling a progressive incremental resistance to be administered. If the patient can tolerate it, test to full strength. Each movement's muscle synergy should also be interpreted. Muscle synergy is the way in which muscles work together in groups to produce the required movements, and with different movements and starting positions, we employ a subtle but different muscle synergy. Therapists may choose to localize positioning to assess specific muscles, and isotonic resistance may also be used to further evaluate. The therapist should be able to recognize when muscle injury should be suspected by the positive finding of pain on contraction, However, a complete rupture of muscle may not be so painful due to excessive nerve damage. Weakness is a classic feature of muscle injury or nerve impingement or damage. A number of authors, including Syriacs in 1979, McGee in 2008, and the Medical Research Council from 1976, have presented grading systems for muscle strength. For resistance testing, the patient can be instructed to contract their muscles isometrically against the therapist's resistance, starting with approximately 30% of maximal strength and gradually increasing the intensity. A patient suffering from a minor muscle strain may find that they can actively contract a muscle with no pain, but cannot do so when resistance is applied. The contralateral limb should be tested first. It's important that careful positioning takes place, that clear instructions are offered, and that the therapist can handle and resist the patient effectively. As stated, mid-range is the usual initial approach, but the therapist may elect to introduce resistance testing in inner to outer ranges or with movement isotonically. Muscle length tests are generally performed as passive movements, although active movements may also be used, to specifically assess for tightness or other symptom response. They are different to standard passive joint movement tests in that they offer important additional information regarding individual muscle length, tension, imbalance, symptom response and pain provocation. The sports therapist may also assess antagonistic muscle relationships and compare contralateral agonists. For this episode, we will just focus on the lower limb. The hamstrings can be assessed as a group by performing passive knee extension from a position of supine lying hip flexion to 90 degrees. The therapist should stabilize the patient's anterior thigh in the 90-degree flexed position and gradually extend the knee as far as is comfortable. A generally ideal position will show us the knee comfortably reaching full extension. Loudon et al. In 2008 described the passive hamstring straight leg raise test, where the leg with extended knee is raised into hip flexion. Less than 80 degrees of hip flexion denotes tightness of the posterior thigh. The therapist can further gauge tightness in biceps femoris by taking the extended knee into a combination of hip flexion, medial rotation and adduction. Tension in the semimembranosus or semitendinosus complex may be ascertained by combining hip flexion, lateral rotation and abduction. Additionally, the gastrocnemius may also be assessed with the hip inflection and the knee in extension. The therapist can appreciate the tension in gastrocnemius as they passively dorsiflex the ankle from this position. Gastrocnemius may also be assessed with firm passive dorsiflexion as the patient is in a prone or supine position and their knee extended. Quadriceps tension may be assessed by flexing the knee in a prone lying position. The therapist should aim to stabilize the patient's pelvis with their forearm and hand as they flex the knee, ideally with the patient's lower leg resting on the therapist's shoulder. This will enable a more localized appreciation of quadriceps tension. If the pelvis is not stabilized, it's likely to rotate anteriorly. The therapist must recognize that any swelling of the knee joint, tendinopathy or muscular strain is likely to cause a painful limitation in that range of movement. A similar prone lying position may be used to gauge appreciation of rectus femoris tension. For this, the patient's hip should be placed in a starting position of slight extension, perhaps resting on a bolster or the therapist's thigh. The therapist can then carefully and passively extend the patient's thigh and importantly recognise that knee flexion will be naturally less than that with the hip in neutral. Of the adductor group, only gracilis crosses the knee, but it may be appropriate to assess the range of both the short and long adductors. Impressions of the short adductor tension can be performed with the patient supine lying, hip and knee flexed 90 degrees, and their foot resting at the inside of the contralateral knee. The leg is then passively lowered towards the couch, and the distance from couch to knee is assessed. Gracilis tension may be assessed, again in supine lying, with knee extension and abduction. The therapist may offer additional hip flexion and lateral rotation. General impressions of hip flexor tension can be assessed by the well-known Thomas test. Although variants of this test exist, it generally involves the patient lying supine with one leg flexed and the opposite resting in extension. The Thomas test is used to gain impressions of the resting tensions in psoas, iliacus, rectus femoris, TFL. The therapist should aim to appreciate that underlying pathology, such as osteoarthritis, could lead to shortening or contracture of the soft tissues at the hip. For the standard Thomas test, the patient should be able to maintain normal lumbar lordosis when lying supine. With excessive muscular tension or joint contracture, the affected hip is likely to be observed being held in a position of flexion and possibly increased lumbar lordosis. The therapist will then place a hand under the patient's lumbar spine so as to feel for a lumbar movement during the test. The patient is asked to flex their contralateral hip and knee until the lumbar spine flexes and flattens. The patient is then asked to hold their knee with both hands. The therapist then observes the resting position of the ipsilateral leg. A negative test shows the leg in a position of extension, still flat to the couch. A positive test shows the leg raised to a flexed position. The therapist overpressure may confirm the tension and the patient may show an increased lumbar lordosis. Iliotibial band tightness may be indicated if the hip rests in a slightly abducted position. This has been described by McGee in 2008 as a J sign. The modified Thomas test has the patient in a similar position, but this time they begin by standing leaning against the edge of the couch and are asked to flex the contralateral leg and hold their knee towards their chest. They are then guided into a supine lying position with the hip and knee still held in flexion, and the ipsilateral limb's resting position is observed as it hangs off the end of the couch. Overpressure can again be offered to the patient's thigh to ascertain resting tension. From this position, rectus femoris length may be observed by gauging the degree of knee flexion. Excessive tension in TFL and ITB may be gauged again by observing an abducted position. The tibia may also be observed for possible deviation into lateral rotation due to tightness in ITB. Eli's test has been used to gauge tightness in the rec fem. The patient is prone lying and the therapist passively flexes the knee to approximately 90 degrees. Shortening of rec fem may be suspected if the hip flexes as the knee is being flexed. The Ober's and modified Ober's tests are used to assess for tension in the TFL, glute medius and ITB. Both tests have the patient inside lying on the contralateral side. The contralateral hip, knee, shoulder and elbow are each flexed to 90 degrees for stability. In the modified Ober's test, the knee is maintained in extension. The therapist stands behind the patient, one hand is used to stabilize and fix the iliac crest, and the other hand is used to offer slight extension and abduction as a start position, but maintaining a neutral rotation position. This ensures that the ITB passes over the greater trochanter during the test. The patient is instructed to fully relax the limb, and the therapist then lowers it into an adducted position. The test involves observation of the hip adducting onto the couch, or early movement of the pelvis during adduction. Essentially, a positive test is where there's minimal hip adduction. A normal range in the modified test is 10 degrees below neutral. Where the pelvis moves early in the movement sequence, or where there's a reproduction of the patient's pain. They're both classed as positive test results. The original Ober's test involves a similar procedure to the modified version, but has the knee in 90 degrees of flexion, which then emphasises TFL more than ITB, and a reduced range of hip adduction is expected. A host of recognised special tests may be used with varying reliability to assess the integrity and condition of specific tissues. This section aims to present a basic overview of the rationale for special tests. McGee, in 2008, states that many special tests can be more accurately performed right after injury during the period of tissue shock, 5 to 10 minutes after injury, under anaesthesia or in chronic conditions. Many special tests still have not been tested for their reliability. Anecdotally and traditionally, many examiners will have tended to use those tests which they found to be most clinically effective. But as the evidence base in this field has developed in recent years, the reliability of special tests is becoming better recognised. Special tests may be single or multiplanar, and they may aim to incriminate a specific structure or simply confirm a dysfunctional condition. Depending on the test concerned, positive findings may include pain exacerbation and apprehension, pain reduction, crepitus, as in a grating sensation, clunking, where one or more structural components move inappropriately or suddenly during the test, laxity, with excessive joint movements or hypermobility, soft tissue tension, joint stiffness or restriction with reduced movement and hypomobility, weakness or loss of muscle recruitment due to motor nerve interruption or a flaccid paresis, abnormal end-feel such as spongy, indicative of capsular swelling, or an empty end-feel, or other obvious joint or tissue abnormality. The uninjured limb should always be assessed prior to the affected limb, so as to provide a comparison specific to the patient. The therapist must appreciate the possibility of false positives or negatives. Special tests must be performed correctly, according to the best evidence, and with confident handling. It's important to note that different textbooks and authors may use quite different approaches to what is apparently the same test. Special tests should be repeated for reassessment, and test findings should be reproducible. There are times, particularly in the acute stage of injury, where certain tests and movements are not reliable due to symptoms such as pain or swelling, or not recommended due to the potential for tissue irritation and injury aggravation. Special tests should always be done with caution, and may even be contraindicated in the presence of severe pain, instability, osteoporosis, active disease processes, unusual signs and symptoms, major neurological signs, or simply patient apprehension. The potential for inaccurate diagnostic findings is reduced if the therapist follows the most recent evidence-based recommendations and specific protocols for special tests. Hattam and Smeatham in 2010 presented a contemporary set of evidence-based special tests for peripheral regions. The sports therapist must have a strong knowledge and practical skill in the delivery of all recognised special tests. Examples of recognised regional peripheral special tests include at the shoulder, Neer's test, Hawkins-Kennedy test, empty can test, apprehension test. At the elbow, valgus and varus stress tests, lateral and medial epicondylalgia tests, Tinel's tap test. At the wrist and hand, Phelan's test, reverse Phelan's test, Tinel's tap test, TFCC or triangular fibrocartilaginous complex load test, Finkelstein's test. At the hip, Thomas test, Ober's test, Faber test. At the knee, valgus and varus stress tests, McMurray's test, Thessali test, Lachman's test. At the ankle and foot, Thomas test, Homan's sign, anterior draw, posterior draw, Taylor tilt test. Specific and careful palpation is an essential component of any clinical assessment. It requires extremely good anatomical knowledge and skill in applying appropriate pressure and depth so as to appreciate different tissue structures and abnormalities. Indeed, palpation should commence superficially before probing the deeper tissues, and should also begin with structures above and below the affected locality of symptoms. The therapist must remain vigilant to the patient's response to palpation, as inappropriate or overly heavy-handed palpation can exacerbate injuries or simply cause great discomfort. Remember that you must be observant of the patient as well as the area that you're palpating. Thorough palpatory examination of any region includes assessment of bony structures, joint lines, all associated soft tissues, temperature and swelling. Palpation should be performed in different joint positions and can also be performed in combination with active, passive and resisted movements, which can allow for different tissues and structures to become more prominent and readily accessible. Soft tissue lesions are often localized and only identifiable with care and specificity. Palpation of muscle tissue may reveal abnormal tone, muscle spasm, fibrous adhesions and thickening, trigger points, atrophy, and tenderness and pain. Tenderness or abnormal contours may also be elicited from other structures. The contralateral limb should be used as a comparison, and the therapist should take care not to aggravate the patient's condition. Bolsters or pillows may be used to support the patient in certain positions. All positive palpatory findings should be recorded appropriately. The sports therapist must recognise that palpatory assessment continues during the delivery of any soft tissue therapy or manual therapy, and frequently important findings will be discovered during treatment. Here now, functional tests are an important part of the assessment as they can replicate essential movements required for the patient's normal daily functioning, their ADLs or activities of daily living. McGee from 2008 describes functional testing as the task analysis, and that it's an evaluation of the patient's injury or disability of their everyday function. Functional tests enable the therapist to identify the patient's normal approaches to movement and whether their movement is a contributory factor in their problem. Such tests may be open or closed chain, bilateral or unilateral, easy or more complex and challenging, and they should enable appreciation of the relationships and influence of body regions, the trunk, the shoulder girdle and upper extremity, the pelvic girdle and lower extremity on all the different particular movements. Functional tests may enable the practitioner to provoke symptom responses in tissues which were not effectively provocated in other movements and tests. The therapist should observe alignment, range, strength, quality, coordination and steadiness of movement, whether any compensation is present, and pain levels. The therapist may observe apprehension or avoidance of correct patterning. This may also be known as performing compensatory movements. Functional testing also offers the therapist the opportunity to coach improved technique and to assess the patient's ability to undertake improved movement patterns. Simple functional tests for the lower extremity may include standing from a seated position and sitting from standing, bilateral and unilateral squatting, partial or full weight bearing, partial or full range, lunging, stepping up and stepping down, picking an object up off the floor, and reaching to a high point on the wall. More challenging functional tests could include simple jogging on the spot, and low-intensity, short-range jumping and landing assessment, which may be bilateral or unilateral, as in hopping. Such tests enable gauging of the athlete's apprehension, ability, pain, stability, proprioception, and endurance. The Star Excursion Balance Test, or SEBT, is a useful and measurable functional test. During functional testing, the sports therapist must be observant for any abnormal movement patterns occurring, such as a valgus collapse at the knee, and also the influence of other regions on movements and positioning, such as poor pelvic stability, tight adductor muscles, or excessive pronation. If the patient is more functional, the sports therapist can request them to perform specific movements of their work or sport, such as a football kick, a stance and swing positions, throw, bowl or swing. Outside of the clinical environment, later stage functional tests can be undertaken, such as speed and agility testing, as in the Illinois Agility Test or the T-Test, and more specific tests. Progressive functional and sport-specific assessment has become an essential component in the improvement of injury prevention, injury management and also sport performance. Gray Cook and colleagues have presented the FMS, the Functional Movement Screen, which is a 7-point measurable and graded movement screen with associated corrective exercise strategies. The seven movements assessed under the FMS protocol are a deep squat, hurdle step, inline lunge, shoulder mobility, active straight leg raise, trunk stability push-up, and rotary stability. It's usual for patients to return for follow-up sessions. It's the sports therapist's responsibility to reassess their patients and record the new findings. Reassessment is used throughout any course of treatment and rehabilitation so as to track the client's progress. A SOAP protocol is the normal approach: subjective, objective, assessment and plan. Any reassessment must begin with a subjective review, which will guide the objective reassessment. Any repeated objective tests should employ the same testing protocols as used in any particular tests previously, so as to ensure consistency and reliability. The objective reassessment will involve observation, active, passive and resisted tests, in conjunction with a selection of special tests relevant to the structures damaged and level of functionality. The experienced practitioner will be able to effectively prioritise subjective and objective assessments so as to save time and work efficiently. It's essential to clarify how the patient has been since the previous session, whether they've had any significant aggravation or whether the condition appears to be improving. The therapist should inquire about any changes to medication, where a reduction in analgesic medication is usually a good sign. Similarly, has the patient noticed that they are now able to undertake activities that were previously too uncomfortable? The therapist should ask how the patient has managed with their home advice and exercise, and ideally the patient should demonstrate any exercises that have been recommended, and then the therapist can ascertain whether the patient has been performing them correctly. Any advancement in rehabilitation exercises must be based on the patient's improvement in functional ability, pain level and quality of movement. If a patient is apprehensive about an exercise, it may indicate that it's too early for them. If their pain level increases or their functional ability decreases, the exercise complexity or intensity may need to be regressed appropriately. Standardised rehabilitation protocols with evidence-based justification should be followed, but adapted to ensure specificity for the client and their injury. Two patients with a similar injury may present and respond to treatment and rehabilitation very differently, and should therefore not receive the same treatment or rehabilitation plan. The therapist must continue to observe and assess the patient during all the treatment and exercise that follows. We hope that you found the information useful. Remember to practice to make perfection more of a practical possibility.
We hope that you found the information useful. Remember to practice to make perfection more of a practical possibility.
Remember to practice to make perfection more of a practical possibility.
Remember to practice to make perfection more of a practical possibility.
Remember to practice to make perfection more of a practical possibility. Remember to practice to make perfection more of a practical possibility.